Should you be taking aspirin to prevent heart disease? Hi, I'm Dr. Eric Westman, and welcome to my channel where I review and debunk nutritional information online. In this video, we're going to hear from Dr. Ford Brewer, who is a preventive medicine doctor who flipped to becoming a low-carb doctor, and we'll hear what he says about aspirin, how he uses it or doesn't use it anymore. And be sure to wait till the end till you hear my final thoughts about this. Confused about cholesterol? Doctor badgering you about medication? Get the facts you need to understand why cholesterol is not the most important thing when it comes to cardiovascular disease, and what to look at instead to assess and reduce your risk. Join me for Beyond Cholesterol, the 2 biggest risk factors for cardiovascular disease. Sign up for my free webinar below.
This little pill, I don't know how well you can see it, but it's a tiny pill, and it has saved about 100,000 lives per year. Really. It's because of its ability to prevent clots, the clots that might end up causing a heart attack. But in the last few years, people have stopped taking this little pill. So why are people stopping now? Isn't it relatively safe? Isn't it something that, it's an over-the-counter, right? Here's what happened. In 2022, the U.S. Preventive Services Task Force changed its recommendation for aspirin for prevention of heart attack and stroke. What they said was not everybody should take it. Now, again, if it's so harmless over the counter, and if it's saving lives, what's going on and why is this happening?
Do you remember back in the day, I was in training in the 80s and 90s when everyone was taking an aspirin, and then it was worried about the coagulation being interfered with and bleeding episodes, that a regular aspirin was reduced to a baby aspirin to reduce these bleeding events from happening. And it was back in the era when the statin drugs were being studied as well, and there were a couple big lifestyle trials. And an important point here in this video is to separate the idea of primary prevention from secondary prevention. Primary prevention is when someone does not have a problem yet, does not have a heart attack or a stroke yet, does not have a stent or heart bypass surgery yet. That's primary prevention. And if you fall into that category, the guideline is now taken away the idea that you should be on an aspirin because of the bleeding episodes. But if you have heart disease, you're in secondary prevention, which you'll hear is probably still going to be recommended. And looking back, though, it takes tens of thousands of people in a clinical trial to show the benefit of a statin drug. It took tens of thousands of people in a clinical trial to show the benefit of aspirin for primary prevention, meaning the absolute reduction in the risk is very, very small. And so even if you are taking it, it doesn't protect you from not having a heart attack. Now enter in a gray area where no one really knows what to do, because if you have a coronary calcium score, or you've done an ultrasound with Lifeline screening, or other company will tell you whether you have disease on your arteries, but you don't have an event yet, are you in a primary or secondary prevention mode? Nobody knows. So let's think about where this data came from, how many people it took to show benefit, and then what aspirin does as an anticoagulant. As Dr. Brewer is saying, it prevents the clots from forming. Clots from forming in your coronary arteries, clots from forming in your veins and arteries all around your body.
We'll talk about how to use aspirin to clear your arteries, prevent heart attacks, prevent strokes. And most importantly, once you begin to understand this, we'll also talk about when to not use aspirin.
Well, so you have to also consider the audience here. And so if you're a patient of mine, you may or may not have had heart attack or heart disease or have a diagnosis yet. You may be trying to lose weight or reverse diabetes. So if you have established heart disease, or you have atrial fibrillation, which is a form of heart disease, you want to be able to separate out the information that's for people who don't have heart disease yet and for those who do have heart disease. It's a very different situation because of the different benefit and because of the different amount of side effects. So let's keep watching.
My name is Ford Brewer. I'm a preventive medicine doc. I started off as an ER doc, and it just drove me crazy that so many people were having heart attacks and strokes and other things that coulda, woulda, shoulda never happened. So I decided that I was going to become something I didn't think I was going to do. I was going to go into prevention. So how does aspirin work? One effect is it improves pain. That's what the Sumerians noticed, and that's what Felix was going for. But there's another effect, and that's what we're interested in today. It's decreasing clots. Aspirin binds to platelets, the little things that start the clotting process, the platelets in your blood. It prevents platelet activation. Other blood thinners, like warfarin, like some of the natural blood thinners, have more of an impact on the clotting cascade. Clotting cascade is a series of a dozen proteins which form together to create a clot after platelets form a lattice work to start the clot. Warfarin and heparin, you've probably heard of those. Those are what we call vitamin K-dependent clotting factors. That's clotting factors 2, 7, 9, and 10. The NOACs, novel oral anticoagulants like Xarelto and Eliquis, focus on one clotting factor alone, 10A. That's a little bit.
So to summarize that, when you have a cut, the first thing that happens is the platelets form a plug to stop the bleeding. When you nick your face with a razor when you're shaving, and it keeps bleeding, if you put a little piece of a paper towel or toilet paper on it, it helps the platelet plug to form so that then it stops the bleeding. So that's why you put pressure on a sore, a cut or a wound to get the platelet plug to start. The platelet plug is easy to take away if you scrape too soon before these clotting factors come in and form the more permanent barrier to stop the bleeding. So the vascular system itself, the artery itself, which gets a little harder to heal as we get older, that is the very important part of this whole process of bleeding and repair. You want to have good vascular system, the arteries and the veins. You want to have good platelets. You want to have good clotting factors in order to heal a bleeding wound. The problem is when we clot too much and we clot in the arteries and the coronary arteries, you can have a heart attack. Or if you clot in your lower legs on an airplane flight or a long car ride, you can have a clot in the venous system in a vein called a deep venous thrombosis, and that can go to the lung and cause a pulmonary embolus. So we want a little bit of ability to stop clots when it's too much of a tendency toward the clots, but we don't want to eliminate all clotting because then we'd have too much bleeding. And that's where the side effects come in with anything like aspirin or warfarin or these other Xarelto kind of anticoagulants. The side effect you don't want is the inability to stop the bleeding or having a bleed. If you have bleeding in the skin, no big deal, it's a bruise. But if you have bleeding internally or bleeding in the brain, it can cause serious problems. So that's the pendulum of the benefit and the side effects. You want to be somewhat in the middle. In general, if you have no risk of a heart attack or a stroke, you would not want to take a medicine that has any side effect to it. So if you have very low risk, that primary prevention place, you are going to be careful to not take a medicine to reduce the risk that's very low. Or now, if you've had a coronary calcium score that's 0, or you've had lifeline screening or other ultrasound that shows you have no carotid or aortic disease, and you're in your 60s and 70s, it means you've lived life without any plaque buildup. You may not want to take aspirin or anticoagulant or statin medicine at all, because you don't even have the tendency to make the disease. Not all people get the atherosclerosis problem, even though it's assumed that you will. You can actually test to see if you have it already, and then help inform the decision of whether you should take a medicine that has side effects to reduce the risk of developing or progressing. That's a different question. So primary prevention, you don't have the problem yet. Secondary prevention, you've had heart disease or a stroke or bypass surgery or a stent, and you make a decision of whether you want to block the clotting more or less or not at all, depending on your underlying situation.
So here was the previous recommendation. Before 2022, the U.S. Preventive Services Task Force said 60 years and older, everybody should take aspirin because you've got risk for heart attack and stroke. If you're curious about my recommendations, no, I didn't recommend that. My recommendation was not unless you had plaque. If you had plaque and no matter what age you were, you needed to consider aspirin prevention. If you didn't have plaque, no matter what age you were, you didn't have to worry about considering aspirin. And
so I like that way of thinking about it, because if you don't have the disease, you don't need to take a medicine to prevent the disease that you don't have. If you were a cancer doctor, you wouldn't just say, here, take this chemotherapy for cancer, because you're probably going to get the cancer. They require a tissue diagnosis of cancer before they give you chemotherapy. So for some reason, our medical system, and partly is these big studies back in the 80s and 90s, it was happening for aspirin, it was happening for the statin medicines, where tens of thousands of people had to be enrolled in the study to show this very, very small difference in two groups. And the risk reduction, absolute risk reduction, is very small for primary prevention, for heart disease. And it probably is because some people didn't have the disease at all, and it was not going to help those people. Can we individualize and say, you're not going to get the risk of bleeding? I don't think we have that ability yet. So you're kind of taking the medicine blindly, not knowing whether you're at high risk for a problem of bleeding. But if I agree with Dr. Brewer, if you have no evidence of atherosclerosis now, then you measured it with a coronary score or a ultrasound, or ideally both, they don't always correlate. Sometimes you might have a 0 calcium score, but you have disease in the arteries, the aorta and the carotid. Sometimes you have disease of the carotid and you have no disease in the coronary. So it's best to get both if you can. But don't take a drug to prevent the disease progression of a disease you don't have. That makes no sense.
Guess what? The U.S. Preventive Services Task Force changed their recommendation to go to what I had been using prior to that. So I'm obviously proud of that. Now, this starts to get into what we call primary prevention versus secondary prevention. Why is that important? When the previous U.S. Preventive Services Task Force recommendation was for primary, meaning even if there's no signs or symptoms of a disease, that's primary prevention. Secondary prevention is you already have a sign or symptom of a disease. So what's the difference between primary and secondary? Why separate those two out? With primary, there's much less risk of continuing on in the disease. Once you already have shown your first sign or symptom of disease, you are much more likely to develop it further and further and further. So that was the issue here. Once you understand the difference between primary and secondary prevention, you begin to understand how the U.S. Preventive Services Task Force really changed their recommendation for aspirin.
And you have to remember the context of most cardiologists, most doctors in general, don't understand the potent effect that lifestyle and diet can have. So if all a doctor has, is a drug to try to use, they're going to be pushing toward using aspirin, even if it has side effects, to treat a disease that they really don't have any good tool for, because in my opinion, that atherosclerosis is a lifestyle disease, and it exacerbates genetic tendencies toward the disease. And so back in the 80s and 90s, what are we going to do with all these people who get heart disease? We don't have any effective treatment, so we'll just push aspirin and push statins for primary prevention, which is not going to yield much benefit, if at all, and brings in the idea of side effects. And then if you're someone who has no disease at all, you're basically being treated for a disease you don't have, which again makes no sense.
Reporters like the New York Times, a really smart physician reporter, still didn't pick up the distinction here. He said U.S. Preventive Services Task Force doesn't recommend aspirin anymore for cardiovascular disease prevention. No, they don't recommend it for primary prevention anymore. They still do recommend it for secondary prevention. And here's one of the other things you should consider. By the time we're age 60, what portion of us have plaque already? The majority. So, again, just boatloads of confusion piling on this change in recommendations. Here's the problem. It was misinterpretation, and again, it was based on the difference between primary and secondary prevention. Now,
to editorialize a little bit here, of course, these studies that have been done, and you can only make recommendations on studies that have been entirely done in people who eat carbohydrates, people who have a dietary contributor to the inflammation. And as Rob Lustig at the University of California, San Francisco really aptly says, that good food is medicine, but bad food requires medicine. So that if you're eating a typical American diet and being put on aspirin, well, that's the result that those studies are going to be given for the interpretation, to be reviewed for the interpretation of these guidelines. If you're changing your diet, you're cutting the inflammation out, the inflammation being the root cause of the atherosclerosis. You may not need these medicines at all. And especially in primary prevention, meaning you have no clinical manifestation, you haven't had a heart attack, a stent, bypass surgery, or a stroke, the incremental benefit of adding something like aspirin or even any other anticoagulant is is guesswork. It's not really clear that these other medicines are going to be advantageous if you don't have the disease, because now you're changing the diet to a good medicine type of diet, so you don't need the medicine to treat the bad food that you used to eat, and most other Americans are still eating. So, and did you hear when he said that the majority of Americans have heart disease? That it's not everyone. So you may be someone who has no heart disease that runs in your family. Family history is still very important. If your parent or sibling had heart disease before the age of 55, or I think just had heart disease at all, it's likely that you may have it, or you're at higher risk of it. If you don't have any family history of heart disease at all, and people have looked, I mean, if you say, well, mom and dad didn't have heart disease, but they never had an evaluation of it. They may have had it, but just never had any clinical symptom of it. So, the more I go along, the more I think not eating the inflammatory foods has tremendous benefit. And it's underappreciated by most doctors, even preventive doctors. And so I'm really leery of asking people to take something that is being used for carb eaters, because those who don't eat carbohydrates don't have nearly as much inflammation going on. But like Dr. Brewer, I still think the secondary prevention benefit is real, and could be part of a personalized recommendation, even from me, to take an aspirin or a statin or some other medication. But in terms of primary prevention, like Dr. Brewer, I agree that there's really no need to take something to reduce or prevent a disease that you don't have, especially if you demonstrated you don't have it when you've lived most of your life.
Now you're beginning to understand another another concept. This whole issue, this risk, does not depend on the amount or size of plaque. You don't have to have 50% blockage or more. That gets back to that concept of ischemia. Ischemia comes from a Greek word meaning stopping blood flow. That requires 50% or more blockage of the artery, the lumen, the place where the blood flows. Now, again, you don't need that much to form a clot. That's the common misunderstanding. It's common sense, and unfortunately, common sense is wrong in this area. You don't need 50% blockage for this to happen. So here's what my recommendation is. Who should consider aspirin? Regardless of age, I recommend baby aspirin, 81 milligrams, to anyone who has no allergy to aspirin, low risk of bleeding, obviously, but has any evidence of cardiovascular plaque. If you have plaque and you don't have allergies or special bleeding problems, you should be taking a baby aspirin.
Well, I interviewed Dr. Brewer on my channel not so long ago and brought up the idea and questioned him, pushed him back a little bit that this is what I do. And asked him for studies where actually, for example, coronary scores or ultrasounds showing plaque but no outcomes, showing that there's actually benefit from taking these medicines. And what's happened now is there's sort of a gray area where you can actually visualize or get evidence where you have plaque or not. And then are you in a primary prevention or secondary prevention category? Well, no, you're kind of in between. And the studies haven't been done, to my knowledge, that the aspirin will help if you've just had a diagnosis of the carotid or coronary by calcium score. And please let me know if you're aware of those articles, because it took tens of thousands of people. In fact, one of the studies was doctors taking aspirin with tens of thousands of doctors doing it to be able to show that really there was hardly any benefit for primary prevention. And so you're going to need lots and lots of people to do studies like this with the gray area of you don't have an outcome yet that's clinically like a heart attack, but you have evidence of some kind of atherosclerotic plaque. Now, it's a safe kind of recommendation to say, well, let's be better safe than sorry. Well, let's take an aspirin if you have that evidence of plaque, but without the studies with randomization and showing that it's no more risky than placebo, for example, you are taking on the risks of the aspirin. And I think still that's an unstudied area where the ability to examine the heart arteries is a little bit ahead of the ability to recommend for sure these kinds of things. So it's using clinical judgment, which in this case, I think Dr. Brewer's judgment is pretty good. But I don't think we know for sure that if you have, let's say, a coronary artery calcium score of 100, which means you've had some healed plaque at some point, calcium is a sign of healing, that taking aspirin will be necessarily beneficial. And you do take on the risks of bleeding from any treatment like aspirin.
The same thing is happening with atrial fib and its risk of strokes. We knew that atrial fib was a major cause, the major individual cause for strokes. We also knew that atrial fib was common. By far the most common rhythm problem with the heart, we knew is much more common as you get older, much more common with people that have prediabetes and diabetes. But we had no clue how many people actually have atrial fib. We still have no clue, but we're finding more and more and more. So back to my atrial fib story. 5 years after I started aspirin. So back at age...
Well, Dr. Brewer had his own experiences and found out that he had some soft plaque in the carotid and decided to change to a low-carb way of eating, and is starting to wake up to lots of different things. The awareness that most people have prediabetes, which really should be called diabetes stage 1. One of my patients told me, if there's anything you should do with the Diabetes Society is you make sure that you call it diabetes, the pre-diabetes, because so many people will kind of blow it off if you just call it pre-diabetes. It can't be that serious, right? And so it's important to understand that pre-diabetes is a significant problem to take action about. Now Dr. Brewer is getting into his own atrial fibrillation story, and I don't have any personal kind of story. I got into this because of two of my patients did it. I don't have a personal weight loss or diabetes reversal story to tell, and I think it makes me a little more objective. Now we get into a doctor who's talking about prevention for other people, using his own experience as a, it could be an anchor or a motivator to help people, but you don't want to overemphasize your own personal experience.
About age 55, 57, I noticed I had the CIMT at the Brad Bale and Deneen event. So I started taking baby aspirin. And then that's when I discovered about 5 years later that I had atrial fib. I was using a home device. It's called iCardio. These devices are available on the internet, online, even places like Amazon. Apple Watches even have these things now. They're about $100. You see, I had felt these palpitations occasionally over the previous years. So I suspected that I might have atrial fib. I had also had some genetic testing indicating I had a genetic variation called 4q25 that put me at risk for atrial fib.
So he said palpitations, which is basically the feeling that your heart is skipping a beat. Or you might even feel a clunk or a thud because you're overfilling one of the beats. So a skipped heartbeat like that, that's new and doesn't just go away like a skipping a beat when you're scared, but it happens frequently, should be taken seriously like he did.
If you're looking for medical care, we're open to different treatments. We're open to lifestyle. We acknowledge from the very beginning that yes, medications are important, supplements are important, but nothing is as important as lifestyle.
Hooray, he finally said it. I was just hoping, okay, come on, what else? What else can you do? What else can you do? Change the diet.
Even all the stuff I've talked about today with NOACs, aspirin, those still aren't as important in preventing heart attack and stroke as the lifestyle components that we've always talked about. Managing your weight, looking for prediabetes, making sure that you manage those risks.
Stopping smoking or tobacco use, of course, hypertension, getting that controlled or reversed by lifestyle change. And then exercise is actually kind of not necessary and maybe even overrated, although I think exercise is a great thing to do once you're in the mood and feeling like you have energy to do it. That's why if you're a patient of mine, and I don't mention exercise at first, but eventually I do bring it up, although most people find themselves spontaneously getting sucked into pickleball or some other activity because they feel so much better after changing their lifestyle. So, I have to say that on balance, Dr. Brewer is still in the old paradigm in terms of thinking that he has to add something. Now, many patients are in the old paradigm thinking, I have to take something to get better and to prevent something, when keep in mind that good food is medicine and bad food requires medicine. And that until there are good studies or evidence of some sort to say adding in more things to a great lifestyle change like a low-carb keto diet is, I'm not going to be recommending things because there are potential side effects of anything that you do take until there's better evidence about it. Of course, if you're watching and you're in a clinical situation and you're taking medications, be sure to work with someone who can help you get off those medicines safely. The deprescribing of these things is very important. The medicines often make people sick early on, and people think it's the diet that made them sick, when actually it was the high blood pressure medicine that made you feel like you were tired because your blood pressure was too low, not because of the diet and the weight loss, but because you were still on a blood pressure medicine that you didn't need. I like that he was self-monitoring. I am a big fan of home blood pressure. If you have diabetes, you really need to be using a continuous glucose monitor for safe, deep prescription when you're on a program like this. And so at the end of the day, like Dr. Brewer says, I think primary prevention is lifestyle. And unless you have documentation of plaque, of atherosclerosis, I wouldn't take aspirin. And even then, if you don't have a clinical event from the atherosclerosis, it's kind of a toss-up. We don't really know for sure. I hope you find that helpful. If you like, please like, subscribe, ring the notification bell. I'm putting out information every Wednesday and Friday. If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.